Hello and welcome to the APTA Oncology Student and New Professional Subcommittee's Diagnostic Downloads. Thanks for tuning in to this month's topic, prostate cancer. We will be diving into the signs and symptoms, treatments, and physical therapy clinical implications regarding the treatment of individuals with prostate cancer. To begin, what is prostate cancer? The prostate is a male organ that sits under the bladder and is responsible for making the seminal fluid that nourishes and transports sperm. Like other cancers, prostate cancer is a result of irregular cell growth. 95% of prostate cancers are categorized as adenocarcinomas, meaning they arise from the glandular cells of the prostate. Prostate cancer is the second most common cancer diagnosis in American men and has an incidence rate of 1 in 9. In the year of 2020, the American Cancer Society estimates about 191,930 new cases and 33,330 prostate cancer deaths. As depicted by these statistics, localized prostate cancer can be slow growing, having a 5-year survival rate of 99%. Distant prostate cancer is more life-threatening with a 5-year survival rate of 30%. And the most common site for metastasis is either in the bones or in the lymph nodes. Moving on to risk factors, the greatest risk factor for prostate cancer is increased age. The average age of diagnosis is 66, and prostate cancer is very rare in men under 40 years of age. Prostate cancer develops more often in African American men and in Caribbean men of African ancestry than in men of all other races. And when it does develop in these men, they tend to be of younger age. The reason for these racial and ethnic differences is currently unclear. There is evidence of some family history of prostate cancer suggesting an inherited genetic factor. However, most cases occur in men without a family history of it. It is important to note that men with a father or brother with prostate cancer more than doubles his risk of developing the disease. In addition, several inherited gene mutations seem to raise prostate cancer risk, although they only account for a small percentage of cases. These genes include, but are not limited to, the BRCA1 or BRCA2 genes and the hereditary gene involved in Lynch syndrome. Other factors that may have an impact on prostate cancer risk, but have less evidence to date, include diets high in calcium, obesity, chemical exposure, and prostatitis. Moving on to the signs and symptoms, early stages of prostate cancer are often asymptomatic. And due to the lack of early warning signs with this disease, it's even more important to be screening men as they age. In more advanced stages, some common signs and symptoms include difficulty urinating, urinary incontinence or urinary urgency, blood in the urine or semen, erectile dysfunction, and pain in the hips, back, or spine. There are many treatment options for this disease depending on the level of progression. In younger men with localized disease, individuals are watched over time through active surveillance of PSA or prostate-specific antigen, looking at those levels, and through repeated biopsies. If surgical resection is needed, various prostatectomy procedures are available to remove the prostate and any additional involved tissue in the surrounding areas. These procedures can be performed through the abdomen or peritoneal tissue, laparoscopically or robot assisted. Next, radiation therapy can be performed either as the primary treatment or following surgical resection to prevent or treat a recurrence. While chemotherapy is not a standard treatment for early prostate cancer, it is included in the standard of care for metastatic prostate cancer that has spread despite hormone therapy treatment. And typically, taxane agents are the chemotherapy of choice that are delivered. Hormone therapy for prostate cancer treatment is called androgen deprivation therapy and works through blocking the production or use of androgens, which prostate cells feed off of. Unfortunately, ADT can lead to a reduction of lean muscle mass and an increase in fat mass, which leads to sarcopenic obesity. And with the average age of prostate cancer diagnosis being 66, this treatment can augment the osteopenia and sarcopenia that naturally result from aging. So this is definitely a side effect of treatment that we want to look forward to in the clinical implications and how we can help slow this deterioration down. Lastly, immunotherapies and targeted therapies are available for treatment. Immunotherapy uses the patient's own immune system to fight the cancer cells, while targeted therapies are created specifically to block the growth and development of the cancer cells. As evidenced by this slide, there are many treatment options for prostate cancer, and the treatment of choice is dependent on the disease stage, personal factors, and patient preference. Now, whether you see this patient for oncologic rehabilitation or for a different form of physical therapy, there are long-term implications of prostate cancer treatment that we must be aware of and help treat. Prostate cancer patients, like most other cancer diagnoses, experience generalized deconditioning and fatigue following treatment regimens. This weakness can be further augmented by androgen deprivation therapy. Lean body mass reduction has been shown to be between 1 to 4% within the first 12 months of ADT. Fortunately, there's strong evidence that multimodal exercise interventions are associated with significant improvements in health and disease-specific quality of life, as well as body composition. Aerobic and resistive exercises mitigate the impact of ADT and promote restoration of muscle mass and reduce bone density loss. In addition to bone density and muscle mass reductions that result from prostate cancer-specific therapies, many prostate cancer patients experience urogenital challenges following treatment, and especially following surgical resection. Pelvic floor specialists can use EMG biofeedback and cues to assist the patient in facilitating the ability to contract and relax pelvic floor muscles. And they can also prescribe pelvic floor muscle strengthening exercises to facilitate better urinary control and reduce erectile dysfunction. So now that we have learned about the signs and symptoms of prostate cancer, available treatments, and clinical implications, let's dive deeper into the role of a physical therapist in the management and treatment of prostate cancer. First off, prevention. As physical therapists, we are advocates for physically active lifestyles. While prostate cancer does not have a direct correlation to physical activity as breast and colon cancer do, research does show that men exercising regularly before and after diagnosis have the lowest risk of prostate cancer specific death. Through advocating for regular physical activity that meets the ACSM guidelines, individuals can help lower their risk of prostate cancer specific death, as well as protect against the deleterious effects of treatment. Next, we must consistently be screening our patients for possible signs and symptoms. Due to the silent nature of this disease in its early stages, physical therapists can advocate for annual PSA screening of middle-aged male patients. Inquiring about urogenital function and episodes of incontinence, urgency, or sexual dysfunction in the subjective taking portion of our examination can help provide insight into possible incidents. And next, as mentioned in the last slide, prostate cancer patients can suffer from fatigue, decreased bone density, loss of muscle mass, pelvic floor dysfunction, and continence problems. Appropriately prescribed multimodal physical activity post-treatment is beneficial in reducing cancer-specific morbidity and mortality. Referral to a pelvic floor specialist should occur when urogenital function is compromised. Our final role as physical therapists working with prostate cancer patients is education. This educational component may exist in the form of behavioral modifications, exercise recommendations, or resource tools. I hope this presentation was informative regarding the need and role of physical therapy within the prostate cancer care continuum. In summary, we know that regular physical activity before and after prostate cancer diagnosis is associated with the lowest risk of cancer-related death. Regular screening of male patients is needed due to the high prevalence of this disease as individuals age and due to the silent nature of its early stages. Physical therapy is beneficial for patients to regain strength and endurance of muscles that were compromised by cancer treatments. Through physical activity prescription and pelvic floor muscle training, we can assist prostate cancer patients in returning to baseline function and needs. And lastly, here are the resources I used to create this presentation and recognize the role of physical therapy in the management and treatment of prostate cancer. Please feel free to look further into these sources to gain a deeper understanding of the physical therapy interventions discussed in this presentation. Thanks for listening in. I hope this was informative and eye-opening.